My special guest today is Professor Jon Emery, who is the Herman Professor of Primary Care Cancer Research here at the University of Melbourne. Thank you for your time.
Thank you.
You've co-authored some research that's going into our upcoming issue about the time it takes patients here in Victoria essentially to get from GP to hospital specialist for their cancer treatment. Why was that necessary to do that research, did you think, and what were you looking for?
So we know that timely diagnosis of cancer is an important contributor to overall cancer outcomes. We've previously published work around that in a systematic review of all the evidence, and the evidence around early diagnosis, even for symptomatic cancer, is now increasingly strong. So we were interested in understanding the experience of patients from development of first symptom to their interaction with general practice until they finally reached a specialist and had their diagnosis made, and really looking to explore whether there were differences between cancer type and whether there were other factors associated with longer time to diagnosis for different cancers.
What were you expecting to find, and did you find it, or was there a surprise or two in the mix?
So we were sort of replicating some work that had been done previously in England, and we used exactly the same survey instrument based on the NHS Patient Experience Survey. And so we're reporting just 2 items from that survey. And we were particularly interested to see which cancers were associated with both a longer time from developing a symptom to diagnosis, but also which were associated with multiple visits to the GP, which we think are a marker of diagnostic difficulty.
Yeah.
So we had an inkling of which cancers from that original research would be associated with diagnostic difficulty. We had sort of less clear hypotheses about which tumour types might be associated with longer overall time.
Right. And what did you find in terms of, first of all, the types of cancers that were more complicated to diagnose, say?
So if we look first at the indicator that we had of having at least 3 GP visits before referral. And so we take that as a proxy for those cancers which are more challenging to diagnose at a general practice level. And we showed that the ones that were most strongly associated with multiple GP visits were pancreatic cancer and myeloma.
Yeah.
Those that were associated with much less likelihood of having multiple GP visits were breast cancer, and then others like melanoma and endometrial cancer. And we think this talks to the sort of the symptom signature of these different cancers.
Right.
So, for example, breast cancer has relatively specific symptoms, and it's easier for a GP to recognise those symptoms as potentially serious and refer promptly on.
Right.
Something like pancreatic cancer or myeloma, they have very non-specific symptoms, particularly early on. For example, they both can present with back pain, but of course the vast majority of people with back pain are not going to have either of those.
Yeah.
And so it's not surprising that we saw those cancers that have very non-specific symptoms that are relatively rare from a GP's point of view. A GP might see 1 case of pancreatic cancer every few years, and even fewer cases of myeloma.
Right.
So you have a low level of expectation and thinking about these as possible diagnoses. So it may take multiple visits for you to actually recognise that this is a potentially serious condition.
So how important is it for the public to be aware of early symptoms of these more difficult cancers, for example?
Well, we think that symptom awareness is another key aspect of this. If we look at the second aspect of the research, which was looking at time from first symptom to eventually being referred to a specialist. And of course, that part of that is the patient component of first recognising a symptom before they actually go and see a doctor about it. And we know from other studies that that's an important contributor to the overall time to diagnosis. And again, what we found was that breast cancer was associated with the shorter intervals from first symptom to seeing a specialist. But it was a different set of cancers that were associated overall with that length of time.
Right. And what was the difference there?
So it was colorectal and prostate cancer.
Okay.
So going back to your question about symptom awareness, and I'll come back to why we think prostate and colorectal cancer had longer intervals. Again, I think what we're finding is that there are certain cancers that have these less specific symptoms that are more challenging both from a patient point of view and also from a doctor's point of view to recognise early. From the patient perspective, there are some key symptoms that a sort of short list of symptoms that you really do need to go and do something about.
Yeah.
And they're the bloody ones. So blood in your pee, blood in your poo, coughing up blood, unexplained weight loss, and then unexplained lump, and then finally unexplained pain.
Right.
So those are the sort of core cluster of symptoms that we would recommend that the public, if you've got any one of those, go and see your doctor. Most of the time they're not going to be due to cancer. No. Because most of those symptoms, although we think of them as serious symptoms, they have much more common benign explanations. So
from a GP's point of view, what does this research tell them and how can they improve their practice?
The really tricky ones like pancreas and myeloma, obviously one has to have a slightly higher threshold of suspicion and at least of thinking about the possibility, particularly if you've had somebody who's come back a couple of times with symptoms that are a bit vague but might potentially be due to a serious condition, then it's about early investigation and then of course the selection of investigations is always challenging, and again I think that's why pancreatic and myeloma you need to be thinking about specific tests to help you diagnose that early. So that is part of the challenge. From a health service point of view, why I think we saw longer intervals for colorectal and prostate may be partly due to what's happening in general practice, about again thinking of the condition and doing the right tests, in particular around colorectal cancer. But then it's also about the delays in the system to get your diagnostic test. Yeah. And so we know that particularly in the public health system, colonoscopy waiting times are a major problem. Yeah. And similarly, access to urological clinics in the public system again is a problem. And so we think that was probably what we were detecting there, that it's more about system access issues as well, probably with colorectal cancer, about awareness of symptoms at the public level and at the GP level.
You mentioned earlier that you were trying to replicate an English study. Were there differences in the results between the English and the Australian situation?
Yeah, so one of the things that I was a little surprised by was the going back to the length of time it took. So we had a cut-off of 3 months. Yep. From first symptom to seeing a specialist. Right. And there was a higher proportion of Australian patients who'd experienced more than 3 months than in the UK. Yeah. And I think what this probably reflects is two things. One, in Australia we have greater access to a number of type tests that we can order ourselves in primary care, particularly radiological tests, and some blood tests are more accessible. And so a GP hasn't got those options to be ordering those tests themselves, and so they're more likely to refer them. Right. And of course the other thing is they have 2-week wait pathways for suspected cancer in the UK. So this has been a major policy and system-wide change in the UK as part of a strategy to reduce time to diagnosis. And so if you have a patient with symptoms that are suggestive of cancer, and there are guidelines created by NICE that underpin all this, then the health system is set up to see those patients within 2 weeks. Wow. I think there is some potential to look at how one might start to introduce these sorts of rapid access pathways. Within Australia now, there's a program called the Optimal Care Pathways that's been gradually implemented. It probably isn't going to look quite like the UK 2-week wait model, but it's certainly trying to identify key time points along the pathway and recommended limits of what those time points should be. Right. And as that gets rolled out, one might expect to see those targets becoming indicators within the health system.
Thank you for your time.
Thank you very much.